Thanks, Mr. Chairman. Thank you, Dr. Professor Mahmoud El-Attar for great opportunity, and thanks to my mentor, Dr. Mahmoud Fuad and Dr. محمد المشتاوي. الكيس برزنتيشن دي هي مراجعة للمحاضرات اللي فاتت. This case of neglected C2 Synchondorsal Fracture, 2 years follow-up. This patient is 4 years old, child presented by neck pain and presented to us by this fracture. It's a neglected C2 fracture of the synchondrosis. This is the flexion and extension views of this patient. It seemed to be a rigid deformity and no movement with flexion and extension. We do CT, multi-slice CT angiography. This is a callus formation, and this is the displacement of the synchondrosis of the C2. This is the MRI of this patient. We think about treatment option, and this boy is very young boy. Either go anterior or go posterior or post approach. What is the fixation option in this child? We review of the literature about the synchondrosal fracture. This is a case report about successful non-fusion management of a healed pediatric odontoid synchondrosal fracture. The authors recommend open reduction and hollow vest for 8 weeks and rigid collar for 4 weeks, and obtained successful fusion. And this is the successful fusion after halo for 8 weeks, and this is a clinical photo. Some authors do a temporary internal bracing for pediatric odontoid synchondrosis in fixation of the C1-2 without fusion, but this boy is 3 years old and very young patient. This author do C1, C2 fixation without fusion and then metal removal after 1 year to preserve C1-2 motion. And this is another retrospective case series study about the synchondrosal fracture. This study, 7 cases, 4 cases were done by posterior only approach, and 3 cases needed a dual approach, anterior release, then posterior fixation. The primary ossifications are C2, 2 vertebral arches and vertebral body, and the dents appear around 6 months and fuse to the centrum by the age of 3 to 6 years at the rim of the subdental synchondrosis. And the secondary ossification center, apex of the dents, most commonly appear from 3 to 6 years and fuse around the age of 12. Back to our case. This is the intraoperative dynamic view to assess the mobility or flexibility of the deformity. And this is the intraoperative. It seemed to be a rigid deformity and fixed in kyphosis after skull traction in the OR. We try to do some traction but failed to correct the deformity, so we decide to go anterior first to do osteoclasis and anterior release. What is the optimal approach or the suitable approach? We do with high retropharyngeal approach. This approach is 2 centimeters below the angle of the mandible from the midline to the anterior border of the sternomastoid, and go superficial skin subcutaneous tissue and open the platysma and dissect the submandibular gland and dissection of the posterior belly of the digastric and preserve the facial artery and the hypoglossal nerve and protect it cranially. And then detect the level of the fracture by a wire, and then try to release of the fracture site and the removal of the callus and open in the fracture site by very small osteotome because the fragment is very small. After do osteoclasis, the fracture begins to free but highly unstable condition, and push C2 from posterior start to reduce partially, and by pressure on the C2 start to be reduced in compared to the preoperative X-ray. After reduction by anterior release, we think about the fixation of this fracture in a 4-year-old boy. So we prepared preoperatively the option of posterior surgery. We do multi-slice CT angiography to measure the lateral mass of the C1 and the availability of the pedicle screw in C2 and detect any anomaly of the vertebral artery, as Dr. Ahmed Shawqi said and Dr. Ahmed Saleh. So we measure the lateral mass of the C1 and the availability and diameter of the C2 pedicle and detect any abnormality in the vertebral artery, either to put a pedicle screw or translaminar screw or bars screw. The measurement of the C2 pedicle as C1 lateral mass on the left side and the diameter of the C1 lateral mass of the right side and the pedicle on both sides. No abnormality of the vertebral artery and good pedicle diameter for pedicle screw in the C2. This is the, we go for Hermes-Gold technique, C1 lateral mass and C2 pedicle screw after reduction, and iliac graft, and we go for C1, C2 fusion, and this is a 6 weeks follow-up. This is the iliac graft and the fusion mass, and this is the 2 years follow-up. The remodeling power in pediatric patient, the C2, the remodeling occur in the C2 and no fracture seen in the C2 and complete bony union at the C1 to posteriorly. And this is a clinical photo of the patient, lateral bend and flexion and extension. هو الفيديو مش هيشتغل؟ لا. خلاص مش مشكلة. خلاص مش مشكلة. My take-home message: pediatric odontoid synchondorsal fracture are rare, usually occur before the age of 7 years, as the subdental synchondrosis is an initial cartilaginous junction between the dens and the vertebral body that doesn't fuse until the age of 6 years. The risk factors include ligamentous laxity, underdeveloped musculature, larger head ratio to the body mass, hypoplasia of C1, C2 facet. The management and the treatment strategies are complex, so careful preoperative planning is mandatory. Thank you.